your question to Kenneth Westbury, who is an NCSD staff member. So once again, if you have a question to pose, please pose it in the chat function in a direct private message to Kenneth Westbury. And for everybody on today's call, please know that we will be prioritizing questions from members of Congress and their staff. So for those of you posing a question, please indicate which congressional office.
Right, so this is the earliest Black Association is created in the 1860s.
We're getting a little bit of background noise. I just want to note for our organizers if there's a way to screen that out. Okay, thank you very much. So once again, welcome today to NCSD's Congressional Briefing, Sex and Suspicion, Sexually Transmitted Infections in America. A few additional notes in addition to the logistical ones I just went over. One of our speakers today, Mr. Sultan Shakir from Washington, has had a death in his family, so he will be unable to join us today. Our sympathies and condolences, of course, go out to Sultan. I am so honored and pleased to be joined by our distinguished and expert panel of speakers today. I really want to thank all of you for taking time out of your very busy schedules to be part of the panel discussion today. And I want to do a special thank you to our participants for the Centers for Disease Control and Prevention today, and in particular, Raul Romaguera, who is the acting director of the Division of STD Prevention, who is presenting today. Before we get into the presentations from our panelists today, I want to acknowledge a very big piece of news within our field. We have had an historic announcement this past week of new funding provided by the Biden and Harris administration, resulting from funding provided by Congress to invest $1.13 billion in disease intervention specialists, sometimes referred to as DIS. DIS have been at the backbone of the public health workforce efforts to prevent STI and to navigate people through the healthcare and testing world. DIS are referred to as different professional terms at the local level, but the media sometimes recalls them public health first responders, disease detectives, case investigators, and perhaps the term that is most widely known in the country right now, which is contact tracing. DIS for decades have been a source of great expertise when it comes to contact tracing. And in fact, up to 90% of the DIS workforce pre-COVID was deployed to COVID response during the course of the pandemic this past year. So as you will hear from today's panelists, STI rates in America are soaring. And in fact, we probably never had the highest numbers that we have in American history as right now. For a 6th year in a row, we have a growing, very concerning problem of babies being born with syphilis. And so an investment of COVID resources and beefing up the public health workforce, DIS, for not only COVID response, but other infectious diseases, we have great hopes for over the next few years in making a dent in these STI rates. So without further ado, it's my pleasure to introduce to you the incoming board chair of NCSD and the moderator for today's congressional briefing, Dr. Shaquetta Johnson, who is the Deputy Director of Operations of the STD HIV program for the Louisiana Office of Public Health. Dr. Johnson, please take it away.
Thank you, David, and greetings to everyone. I am Shaquetta Johnson, Deputy Director of Operations from the Louisiana STD HIV Hepatitis Program, and I bring you greetings from the Bayou State. I'm delighted to join you here today for this very important discussion of sex and suspicion, Sexually Transmitted Diseases in America. For those of you not so familiar with the National Coalition of STD Directors, or NCSD, NCSD is a membership organization with 65 full members from states, territories, and large cities with hundreds of associate members. NCSD offers advocacy, training, and education around programmatic and policy work, as well as state policy assistance. The organization is based in our nation's capital, Washington, D.C., and I am proud to currently serve as chair-elect of the NCSD Board of Directors. The vision of NCSD is a nation without STDs, and we recognize the inequities that persist in STD rates across the country. As with many things in our world today, STD prevention does not exist in a vacuum, and there is well-documented mistrust in the healthcare delivery system, particularly among minorities and vulnerable populations. That mistrust we've seen play a significant role in presenting challenges in the planning and execution of the COVID-19 pandemic response efforts. Many aspects of that mistrust in the system also create significant barriers for us as we try to effectively address the STD epidemic that we have faced for many years in this country. The panel we've assembled here today are champions in the fight to overcome those barriers. All three panelists are well-respected leaders in the field.
Shaquetta, you're muted.
Oh, I'm sorry. Okay. I'm sorry. I've been talking away. Well, thank you, David. And greetings to everyone. I'm Shaquetta Johnson, Deputy Director of Operations with the Louisiana STD HIV Hepatitis Program. And I'm delighted to join you here today for this very important discussion of sex and suspicion, sexually transmitted diseases in America. For those of you not so familiar with the National Coalition of STD Directors, or NCSD, NCSD is a membership organization with 65 full members from states, territories, and large cities with hundreds of associate members. NCSD offers advocacy, training, and education around programmatic and policy work, as well as state policy assistance. The organization is based in our nation's capital, Washington, D.C., and as David said, I'm proud to currently serve as chair-elect of the NCSD Board of Directors. The vision of NCSD is a nation without STDs. We recognize that inequities that persist in STD rates across the country. As with many things in our world today, STD prevention does not exist in a vacuum. There is well-documented mistrust in the healthcare delivery system, particularly among vulnerable and minority populations. That mistrust has presented significant challenges in the planning and execution of COVID-19 pandemic response efforts. Many aspects of that mistrust in the system also creates significant barriers to us in effectively addressing the STD epidemic that we face in this country. The panel we have assembled here today are champions in that fight to overcome those barriers. All three panelists are well-respected leaders in the field of STD prevention who have for many years been working to build trust and cultural humility in the communities in which we live and serve. We hope you walk away from today's discussion with not only a better understanding of why those inequities exist in the STD rates that are reported, but also an appreciation for the effective strategies that have been put into place to address those inequities and have resulted in a more positive impact in the lives of the individuals and the communities behind those numbers. I'd like to now introduce our distinguished panel. First, Dr. Raul Romaguera. And Dr. Romaguera is the Acting Director of the Division of STD Prevention at the Centers for Disease Control and Prevention, National Center for HIV/AIDS, Biohepatitis, STD, and TB Prevention. Prior to this role, Dr. Romaguera served as Deputy Director of DSTDP where he played a key role in setting the strategic direction of the division and led policy planning, partnerships, and communications activities. With over 38 years of experience in public health and public service, Dr. Romagera has also held positions at the Health Resources and Services Administration, in the Office of the Assistant Secretary for Health, and several other positions at the CDC. Next is Ms. Melberta Bender, who is Director of the Office of STD HIV at the Mississippi State Department of Health. Ms. Bender oversees STD and HIV prevention, testing, education, field services, epidemiology and surveillance, viral hepatitis, and Ryan White Part B care and treatment services. She is an engaged member of NCSD and the National Alliance of State and Territorial AIDS Directors. And last but certainly not least, Dr. Philip Chan. Dr. Chan is an associate professor at Brown University in Providence, Rhode Island. He is also medical director at Rhode Island Department of Health and serves as chief medical officer at Open Door Health Clinic in Providence. And now, without further ado, I will turn it over to Dr. for his presentation.
Thank you. Thank you, Dr. Johnson, and good afternoon, everyone. Next slide. Today, I want to share with you some updates about increasing rates of STDs, the disruption of STD services caused by COVID-19, health disparities associated with STDs, and opportunities for STD prevention. Next slide. Next slide. Less than 2 decades ago, gonorrhea rates were at historic lows. Syphilis was close to elimination, and advances in chlamydia diagnostics were making it easier to detect infections. So where are we now? In 2019, chlamydia, gonorrhea, and syphilis cases reported to CDC increased for the 6th consecutive year, reaching an all-time high. Notably, since 2015, the cases of syphilis increased by 74%, and the cases of congenital syphilis by 279%. And almost 1,900 cases of syphilis were reported among newborns in 2019. Next slide. STDs remain common and costly. A recent study conducted by CDC estimates that in 2018, 1 in 5 people in the US had a sexually transmitted infection on any given day. There were an estimated 26 million new sexually transmitted infections in 2018, with a total direct medical cost of $16 billion. And this doesn't include associated costs such as lost work, transportation, and childcare for appointments. Note that these figures include estimates for 8 sexually transmitted infections and include chlamydia, gonorrhea, and syphilis, which are the 3 reportable conditions that are included in CDC's annual surveillance data. Young people ages 15 to 24 account for about 16% of these costs, and chlamydia, gonorrhea, and syphilis combined account for more than $1 billion of these costs. Next slide. STD programs were already working hard to address STD increases in 2019, and then COVID struck. These had repercussions for STD clinics and for STD programs, whose disease investigators, also known as DIS, are often called to conduct case investigations and contact tracing during an outbreak. COVID-19 was no exception, but it also exposed systemic health and social inequities that put racial and ethnic minority groups at increased risk of many infectious diseases, including STDs. In December 2020 and January 2021, CDC surveyed select jurisdictions to assess the impact of COVID-19 on STD clinics. Overall, 15% of jurisdictions closed their STD clinic at least once, 22% reduced clinic hours, and 65% implemented telemedicine visits. Jurisdictions also reported test shortages and reductions in clinic visits. Next slide. STD prevention programs also experienced disruption due to COVID-19. 620 STD staff across 40 jurisdictions were reassigned from STD to COVID-19 work, and 53% of jurisdictions discontinued disease investigation for HIV and STD altogether in 2020. Additionally, 28% of jurisdictions reported that DIS were permanently reassigned to COVID-19 work. Next slide. This graph shows 2020 STD cases as a percentage of 2019 cases. Compared to 2019, the number of STD cases reported in 2020 initially slowed due to COVID-19, but eventually rebounded. And by mid-June 2020, gonorrhea and syphilis exceeded the number of cases reported by June 2019. Next slide. Next slide. The health disparities that exist in STDs demonstrate the stark structural inequities that persist in the US. In 2019, rates of STDs among Hispanics and Latinos were 1 to 2 times that of white people. Rates for American Indians, Alaska Natives, or Native Hawaiians and Pacific Islanders were 3 to 5 times that of whites. And rates of STDs among African Americans or Blacks were 5 to 8 times higher than that of whites. CDC continues to work with partners to address these inequities, but public health programs alone cannot address these long-lived trends. Next slide. One way that CDC has worked to address STD disparities at the community level is through a program we call Community Approaches to Reducing STDs, or CARS. The purpose of CARS is to identify societal issues that contribute to disparities, such as access to quality health care, and to develop interventions that address those societal issues. It also promotes personal wealth and advances community wellness. CARS has awarded a total of $12.6 million to community-based organizations from 2011 through 2020. The current cycle of CARS, which started this year, awarded $1.2 million equally to 4 organizations. The interest in this program is great, but this year we were only able to fund 8% of qualified applicants. Next slide. As you can see on this map, congenital syphilis is everywhere, with the highest burden in the West, Southwest, and Southeast. In 2019, 43 states, plus the District of Columbia, reported at least 1 case of congenital syphilis. Next slide. Congenital syphilis has been on an alarming upward trend, increasing every year since 2012. From 2015 to 2019, congenital syphilis-related death increased 256%. And in 2019, there were 34 infant deaths and 94 stillbirths. Next slide. Next. Syphilis during pregnancy is associated with miscarriage, stillbirth, preterm delivery, prenatal death, and congenital infection. Rates of reported congenital syphilis cases increased for all races and Hispanic and Latin ethnicity groups during 2015 to 2019. The largest increase was among American Indian and Alaskan Native people. Next slide. In summary, STDs have increased for the 6th consecutive year. The COVID-19 pandemic has further exposed systemic barriers and health inequities faced by communities of color that have been reflected in our STD rates for many years. Acknowledging inequities in STD rates is a critical first step toward empowering affected groups and the public health community to collaborate in addressing inequities in the burden of disease. Our ultimate goal is to minimize the health impacts of STDs on individuals and populations. Next slide. There are several exciting opportunities for STD prevention that CDC's STD program is currently pursuing and implementing. In December 2020, HHS released the Sexually Transmitted Infection National Strategic Plan. And this March, the National Academies of Science, Engineering, and Medicine, or NASEM, released a report on sexually transmitted infections. Addressing disparities is a key component in both reports, and CDC's STD activities and plans will reflect this focus. In addition, and as a result of COVID-19, innovative strategies and solutions have been adopted to meet people where they are and expand access to testing and treatment. For example, STI Express clinics for walk-ins, partnerships with pharmacies and retail health clinics, and implementation of telemedicine. Next slide. CDC is also very pleased to have received funding through the American Rescue Plan Act to address the staffing, training, and technology gaps created or exacerbated by the COVID-19 effort by state and local STD programs. It includes an investment of $1.13 billion over 5 years. This much appreciated influx of funding will help us to address COVID-19 and other infectious diseases while strengthening our public health departments. Thank you.
And thank you, Dr. Romagera. That was a very informative presentation. And now we'll turn it over to Ms. Bender from the Mississippi State Department of Health, and she'll discuss how they have been building prevention and care services in Mississippi to reach priority populations and communities. Ms. Bender?
Hi, thank you, Shaquetta or Dr. Johnson. So I was thinking about how to begin this presentation or this discussion, but
You're muted right now.
sorry, I was prepared for that. Thank you. So in thinking about today's discussion and presentation, I kept going back to our national STI strategic plan. And I don't know if many people are aware, but this is the first time that we've kind of had a full-fledged plan that is focused on STIs. And we also have a national strategic plan for HIV, and we have the EHE epidemic. So in my thought process with where we're trying to head with our STD HIV programs is how we can leverage all of those connections to have a greater impact in areas where there is little impact. COVID has really made it difficult to meet people where they are. And when I say that, I mean traveling for our DIS or our social workers. And as was pointed out earlier, it really has exacerbated or revealed to us where we are deficient in some of our resources and in our services. So at the Mississippi State Department of Health, one of the things that we don't do is sit and say that we're the only ones experiencing this problem. We try to research and talk with other groups and look at best practices on what we can do and how we can do it better and if we can do more. The American Rescue Plan, the funding that we receive for ending HIV epidemic through prevention as well as through HRSA, all of those should be looked at and reviewed as a way to expand the resources that we currently have. The STI Strategic National Plan, for some, it may not mean much. For me, it means a lot. What we will need to do, just like we have an HIV Planning Council, is have a community advisory board for STIs. And somehow those boards need to work together, merge not only resources, but merge minds, because after all, HIV is an STI. So why can it not be part of the conversation? We have, with our planning, expanded the number of community engagement partners that help with some of our planning around HIV prevention, as well as STI. And the uniqueness of that is that these are voices that have not traditionally been at the table. So oftentimes I've attended meetings and we talk about certain target populations and how we will address their needs, but those populations are seldom at the table to express their point of view and their concerns. As you know, Mississippi is very rural, and with that comes limited resources including access to quality health care. So there may be a county health department, but what we lack is holistic care for STIs, transportation needs, considering what the priorities might be for a person who's experiencing symptoms that might be an STI, but maybe they're hungry. Maybe they need to get to work. So there are other priorities, and we talk about this with HIV as well. But with STIs, I feel most of what we've done is crunch the numbers and present data. We have an integrated HIV prevention and care plan, but what have we done with that plan? So this time around, what we want to do to address building our presence in the community around STIs and not sort of show up suspiciously as we're talking about for this topic, because if you're presenting yourself in particular population groups and you're talking about STIs, we want to be able to refrain from the fact that we're saying that this group has more STIs than another. We may know that, but how we present ourselves and enter communities will play a large role in how we begin to build trust or rebuild trust. We've heard from some community members that there are issues with trust, but I can actually count on one hand how many people have addressed that with me. My concern is if you're saying there's distrust or mistrust, what does that look like? Because without having evidence or without knowing what the primary issues are, even if the health department is on the ground or in the community, we still may fail to get to the crux of the matter. So what we're trying to do is be more present. We know that most people are zoomed out, but the best way we can with some of our community engagement partners is help them decide how best to deploy their resources, how best to address the needs in the community, how best to address or answer the questions when trust is an issue. And as we develop our media campaigns or any other avenues that increase our presence in the community, be physically there, be there listening, and walk away with an active action plan on how we plan to come back and provide resources or be the voice that we have not necessarily been for STIs. Thank you.
Thank you, Melberta. I think you brought up some excellent points. I mean, just looking at, like you said, touching on tried and true concepts like community advisory boards and using them for the purposes of STI interventions, engaging with non-traditional partners, making sure you have those voices at the table who aren't usually there, but making sure they're a part of the conversation. That's excellent. As well as the importance of how we present the data. We know what the numbers say, but being culturally sensitive and appropriate in the way that those facts are presented, those things can definitely help to build the trust with the constituents we're trying to reach. So thank you for sharing that. And so now we're going to turn it over to and have a special introduction of Dr. Chan from Senator Jack Reed. I think we have a video.
Hello, I'm Senator Jack Reed of Rhode Island, and it is my pleasure to be able to introduce all of you to Dr. Philip Chan. As you can see from his biography, Dr. Chan wears multiple hats in our state, serving as a professor at Brown University in both the School of Medicine and the School of Public Health. But if that's not enough, he is also the medical director of Rhode Island's only publicly funded STI clinic at the Miriam Hospital, medical director of the Open Door Clinic, which is the state's first clinic specializing in care for the LGBTQ+ community, and a medical director in the Rhode Island Department of Health. Most recently, our state relied on his expertise in infectious disease control and contact tracing to help inform the COVID-19 response. In fact, he has been one of the leading experts in Rhode Island in combating this pandemic, and we are also grateful for his work and dedication to serving us through this challenging time. But most importantly, Dr. Chan works in these roles with compassion and understanding, which is why he is so uniquely qualified to work with vulnerable populations. We are so lucky to have him serving the community in Rhode Island. Thank you.
And now I present Dr. Philip Chan.
Thank you, Dr. Johnson. And I also want to thank Senator Reed for that very kind introduction. You know, one thing that I love about the state of Rhode Island is that we are a small state. Everyone really knows each other, and generally we all work really well together. So come and visit us in the Ocean State once this pandemic is over, perhaps. But I also want to thank you all for being here today. I want to thank NCSD for organizing. And I'm pleased to be here today to talk about how to address the exponentially increasing number of STIs in the US from the perspective of a community-based clinical provider. So as an infectious diseases provider, I've really spent over a decade working to address STIs in the community. I'm going to share some of those experiences, lessons learned, and future direction. You've heard today about the increasing burden of STDs across the country, and importantly, the disparities that exist in STIs from coast to coast. And despite decreases in HIV, STIs continue to increase in every state that's represented here. And we've heard and we know that these disparities persist in certain groups, specifically and including Black, African American, and Hispanic Latino communities. And then at the end of the day, you know, we just need to do more. And I'll talk a little bit more about that as well. But one key thing that we've also heard about is how important trust is in building relationships and in providing culturally competent STI care and treatment. And from a physician perspective, I really can't overstate the importance of trust. We know that many providers, unfortunately, do not talk about sexual health with their patients. We also know that people who do not talk to their medical providers about sexual health are less likely to be tested for STIs and therefore more likely to unknowingly spread STIs to a partner. And there are many reasons why medical providers may not talk to patients. I spend a lot of my time talking to my colleagues, to primary care providers, other providers, about the importance of this and about talking about sexual health. And there's lots of reasons that I hear, and these include not feeling as though there's enough time. We all know that the medical community is often strapped for time. There's so many things to discuss. A lot of providers are uncomfortable about talking about sexual health topics. And we also know that a number of providers and clinicians and people in general just don't know how to talk about sex in an appropriate manner and with patients. And so here's the conclusion I've come to after a decade in this field, that the key to building trust among patients include treating all patients, regardless of backgrounds, regardless of race, ethnicity, sexual orientation, gender identity, is to treat all patients and people, frankly, with respect and to be non-judgmental. And this is absolutely critical, and it's the foundation of building trust. If you don't respect someone, you're not going to earn their trust. And what I've seen and what the conclusions that I've come to is that medical providers, clinicians, physicians, nurses, nurse practitioners should not make assumptions about patients, including that everyone is heterosexual or that everyone's a certain gender. And also, we also shouldn't assume that, for example, that someone is not having sex. And this is a common mistake, for example, based on their age. And I'm reminded that older people have sex too and can also get STIs. So being respectful and non-judgmental is not only the right thing to do, but it also allows us physicians and other medical providers to obtain critical history so that we can discuss the best care and treatment options for a patient. This may include things like HIV, pre-exposure prophylaxis for HIV prevention, or other approaches to prevent future STIs. So in a non-pandemic setting, I'd pose this question and perhaps even ask people to raise hands, but let me ask people on this. Obviously, don't answer this, not that you can on this Zoom call, but just think to yourself, at your last clinical encounter, last time you saw a doctor, medical provider, nurse, anyone, did they ask if you were sexually active? Did they ask the sex and gender of your partner or partners? Did they ask if you use condoms? Did they talk to you if you were at higher risk of HIV? Did they talk to you about PrEP? Did they ask you if you knew about PrEP? In the past and pre-COVID, I would usually find that less than a quarter of people in the room would answer yes to any of these questions. And that's a problem. And I'll also share an example of a patient that I saw recently, a young Hispanic Latino cisgender gay gentleman who I recently saw. So he was in his late 20s, and he mentioned to me that no doctor had ever asked him about his sex life. And this is despite the fact that he was having multiple partners, he was at higher risk of STIs based on his age, his sexual behaviors, and the community he lived in. And he mentioned that he was nervous about talking about it today. And I told him, and I'd never met him before, and I told him what I tell all my patients, and this is generally what I encourage providers to say. And this is almost word for word when I generally talk to my patients. You know, I say, look, my goal is to help you be as healthy as possible. I understand that some of what we're talking about is sensitive, but the more you tell me, the more I can help provide some suggestions on how to help you stay healthy and prevent STIs, including HIV. And at the end of the day, I really just want to help you. And something that Ms. Bender said, to meet you where you're at. And that's where I come from as a physician, where I think that we need to come from as a clinical community, is to really meet patients where they're at and work with them to develop a care plan that really fits their needs. And the patients I mentioned, that I had just mentioned, went on to share his story with me. We tested him for STIs and we got him on PrEP and hopefully prevented a future case of HIV. So the moral of that story is that it's not that hard to talk to patients about sex. And the other thing I usually tell people is that the person in front of you, the patient in front of you, is only as uncomfortable as you are. Meaning, if you ask questions in a direct, straightforward, respectful, non-judgmental manner, is that patients will tend to honestly answer. And at the end of the day, everyone is helped out. Again, the key is to be respectful and non-judgmental. So how do we create clinical services which build trust and address STIs? So first, we need to appropriately train clinicians and provide resources for education and support. I think the CDC does a great job at providing resources, developing resources, very robust communications. And we at the local level need to be effective in reaching out to communities and clinics and providers to disseminate this material and to train clinicians. And there are programs that the CDC funds to do that, and we need to do a better job and to continue doing that. We also need to improve access to STI care and support safety net services, especially in geographic hotspots, including publicly funded STD clinics and primary care clinics. I firmly believe that access to primary care and STD clinics is STD prevention. We need to make sure that all of America has access to primary care. We know from data, certainly during the pandemic, that people have had less access to primary care and have prevented less. So we need to work post-pandemic, certainly, to improve and get people back to primary care and being tested for STDs. We also need to work to overcome barriers which exacerbate some of these disparities to STDs, which we've been talking about. And this includes improving access to clinics in hard-hit areas. Again, geography. We need to make sure that language services are available if needed. We need to address transportation issues. We need to ensure confidentiality. So this is listed as one of the #1 things of concerns regarding STI care and treatment and testing. For example, we need to work on insurance statements and make sure that people aren't being mailed home sensitive explanation of benefits, which may contain evidence of STI testing, et cetera. And I think most importantly, we need to move to a point where we can improve access to insurance and to lowering out-of-pocket costs. And the two top things that we hear as barriers to STI care as a clinician, as a physician, is maintaining the confidentiality and the fact that out-of-pocket costs are too high. So the #1 and 2, that's actually 1 through 10 from what I hear on a daily basis. So we need to work to address those both at a federal and a local level to do better in terms of STD care. And related to that, and finally, we need to incentivize the clinical community to test for STIs, and importantly, continue to provide funding to clinics and initiatives to address STIs in the country. And one example that Senator Reed mentioned, and I'll just share what we've done here in our community here in Rhode Island, is that I was part of an initiative to open an LGBTQ plus community health center here in Providence, Rhode Island, here in the geographical hotspot of STIs called Open Door Health in Providence. There were no STI clinics in the area that we opened, despite it being the geographical hotspot. And so I partnered with Dr. Amy Nunn, the executive director of the organization, and with support of the Rhode Island Department of Health. I see Tom Bertrand on as well. He's chief of our STI division here at Rhode Island Department of Health. But we opened this clinic in the hotspots. And it's these initiatives and ones like these that we need to do in order to get a handle on the STI epidemic. Improving care, novel approaches, push in the box, initiatives like clinics, like access to care. And if we've learned anything from the COVID pandemic, it's that we have to make our clinical services friendly and accessible. Per Melverta, we have to meet people where they're at, those who are most at risk, whether it be COVID or STIs. So thank you again all, and be well.
And thank you, Dr. Chan. And I want to thank all three of our panelists for excellent presentations. I think, one thing that I can definitely say from all of the presentations, there's value in this discussion. And I think in the work that we do, we know there's not just one approach that's going to be the cure-all for the STD epidemic. There's value in the data and statistics that Dr. Romagera shared, because that helps us to effectively allocate those limited resources that we have to do this work. We heard from Melverta about how we can engage and meet people where they are, bringing those non-traditional voices to the table, asking them to help us create effective strategies that will address the needs that they see in the community. And also the important word from Dr. Chan about being respectful and also non-judgmental in the work that we do as clinicians. And I think we all understand that at the foundation of a good working relationship with your clients is trust. And you get that through mutual respect. You want them to respect you, but you then have to respect that client. So this is wonderful information. And I think we want to have a chance to get to as many questions as possible. So I'll start off with one question. I think it's really important in our current state of the country. How has COVID-19 impacted mistrust in the communities that you serve? And what actions can the field take? And I'll pose that to either of the panelists that would like to jump off with an answer.
So I can answer first. So I am hoping actually that the COVID pandemic has improved some degree of trust among communities. So what we've tried in our state, and I've seen other states do this as well, is really elevate the importance of public health. So certainly related to COVID, I am hoping, of course, that some of that will lend itself to STIs as well. We've done a lot of outreach here in our state. We've set up clinics for testing, for vaccinations within our hardest hit geographical hotspots. It's a lesson that we've learned from, for example, HIV STI testing. We have to get into the communities that are hard hit. So I'm hopefully optimistic, actually, that we've certainly garnered some trust, if you will, from some communities. We've done a lot of community forums, answered a lot of questions. So I'm hoping that the stock, if you will, of public health has risen a little bit, and hopefully there will be a little bit more trust in some of these communities.
Melverta, I would like to echo Dr. Chan. I would say that early on there was some mistrust with COVID, but that had a lot to do with the fact that so many of us were learning and trying to understand what did it mean to be, to have COVID, how did it impact jobs and family, and so people were initially reluctant to share information and may not have shared readily the necessary information to do contact tracing. What I am most excited about is the attention that it has brought to disease investigation specialists or to contact tracing, which definitely has been elevated by the recent release of additional funding. So I'm like Dr. Chan, I'm going to look at the positive. People were scared, concerned, worried. Certainly we didn't think that more than a year later, we would still be having the COVID conversation. but now it's just part of everyday news reports, everyday education. And as it becomes that within the community, the positive influence that we have an opportunity to have within communities that are heavily impacted just increases exponentially, I do believe.
Okay, great. I think those are both excellent points. Kenneth, were there other questions from the audience?
Hey, yes, good afternoon. So this question is for Raul and other panelists, if they feel inclined. It says, because the CDC does not recommend testing and does not track herpes, there is substantial mistrust in the CDC's STD, HSV prevention strategies. There's nothing being done to prevent the spread, despite it being the largest STI with no cure globally, and its disparate impact on women, Black, Hispanic, and LGBTQ populations. Why is HSV 1 and 2 not included in these studies and statistics?
Yeah, thank you for the question. CDC currently focuses on 3 bacterial STDs, mostly because these are treatable conditions that we can actually address promptly. HSV is not a reportable condition to CDC. And just I would like to add that CDC doesn't decide which conditions will be reported to CDC. That is a decision made by all the state epidemiologists in coordination through the Council of State and Territorial Epidemiologists. So currently we don't have any way of tracking HSV in this country. The tests for HSV are not reliable, so therefore CDC is not recommending HSV testing.
So who's working on better testing? If the tests are not reliable, who is working on better testing? Because that response is not acceptable. Herpes is the largest STI globally with no cure. If the tests are not accurate, you need better tests. This impacts Black, Hispanic, LGBTQ. It needs to be addressed. Thank you.
Thank you, Ms. Neff. We're working with NIH to assure that new tests and more reliable tests are developed.
Awesome. Thank you, Raul, for that one. For participants, we would like to allow our panelists to complete their question and answers to the question before coming in. If you have any direct questions or responses, you can feel free to chat me directly. My name is Kenneth Westbury. Okay, awesome. The next question is, so everybody's talking about stats. Nobody's talking about cures. There was a participant that wants to know how manufacturers and industry professionals can assist with bringing STD testing to the people. And anybody's welcome to.
Yeah, so I can take first shot at that one. So one of the things that I initially led early on in the pandemic was COVID testing. And everyone remembers that was a little bit of a struggle in the beginning. But I think, there's so many lessons that we look at COVID testing, for example, that can and should be applied to STI testing. What have we seen for COVID testing? One, we've seen in a lot of states, multiple clinics, testing clinics, pop up across the state in key spots. And that's what we did in Rhode Island. It allowed increased access. What's another thing that we've seen? We've seen point of care testing, right? For COVID-19, which is now a big thing. You can walk into Walmart and buy a pack of Binax Now tests for pretty cheap to test. And so these advances, I'm hopeful that we've seen for COVID-19, both in terms of understanding how to reach some populations that may not test, and also some of these diagnostic advances, I'm hopeful will translate to things like STIs so that we can address. So I think there's lots of lessons that we've learned in COVID-19 and hopefully moving forward and certainly post-pandemic we can apply.
Awesome. Thank you, Dr. Chan. The next question is for Ms. Bender, Alberta. You mentioned that it's important to engage non-traditional partners in the space. Can you highlight who these partners might be, maybe from your experience or from your recommendation?
So yes, thank you for the question. Even with our Mississippi HIV Planning Council and some of the organizations that the STD HIV program at the health department have supported through funding or other resources to engage the community, we engage those partners to target resources to certain population groups. However, many of those population groups, for example, survival workers, transgender nonconforming, Black transgender, many of those voices are not necessarily at the table providing advice. And rather the data that we are able to collect, or people who work in those communities are providing guidance and advice on how to address some of the issues in the community with HIV and with STIs. And I know I keep mentioning ending the HIV epidemic, but what is very unique about that funding is that it has said to us in every jurisdiction that's been funded that you can no longer just have conversations about your target populations that need resources or need testing or may need something else that has not sufficiently been addressed. You actually have to have them providing that feedback directly to the STD HIV programs that we have. And I think we have not done the best job of that. I'm hoping that we'll get better. And that probably has contributed to a lot of the mistrust between the health department and the community, because we continue to have conversations with the same groups of people. And those same groups of people are speaking for people who have not had an opportunity to speak up for themselves. It took a while for us to get to this point for the mistrust to develop. And so I don't want to have our program or the health department rush in with a one size fits all. This is our collaborative, this is the advisory group, when it's going to take more than that. There may be an intervention. We may even fail at many attempts, at different attempts to engage certain communities, but we are open to failing until we get it right.
Thank you for that one. Appreciate that. This one is directly from congressional staffers. So as congressional staff, what can we do to curb the STI pandemic? I think that would be great for all panelists to answer.
Kenneth, why don't I start out having a crack at answering this on behalf of the staff of NCSD. A couple of things. Thank you for this question. For those of you who are congressional members of staff, you have a special role to play in several different ways in supporting policies that will curb the STI epidemic in America. First and foremost, I would talk about money and resources. The STD prevention program at CDC is woefully underfunded. Even with the infusion of COVID money to support DIS, there is still the funding needs of the base program that supports STD prevention programs at the state and local level in the United States. Only about 161 million is allocated per year by Congress. We desperately need more funding allocated to that. So if you happen to sit on the appropriations committees, we would be happy to follow up and talk much more with you about that. Second to that, visibility of these issues. Congress has a role to play in raising the visibility of this epidemic in America. And we would encourage several things. One, having your member visit an STD clinic back in their district to bring some visibility to this issue and to provide much needed recognition and support to the hardworking staff who work every day in these programs. The second thing, members of Congress have a huge role to play in media coverage, placing things in the congressional record, anything that you can do to help promote awareness of the scope and the scale of this epidemic in America would be very important to do. In addition to supporting the base STD program at CDC, there is a focus. We've already heard some comments. There's some real energy around herpes and what is or is not happening at NIH. That's not the focus of today's briefing, but it could be and should be a focus of a future briefing. NIH funds very important clinical trials related to treatments and diagnostics. And NIH needs to be the focus of advocates' interest in supporting a greater level of attention to these issues through the NIH process. So, and then last but not least, there is no, other than a smaller funding stream through the Ending HIV Initiative, there really is no independent federal funding stream for STI clinical services in America. Most STD clinics across the country will tell you they exist on a shoestring budget, patchwork pieces of funding that come from various grants and private sources. NCSD happens to believe there should be an independent federal funding stream that supports STI clinics, standalone STI clinics, as well as STI clinics that are based in larger healthcare institutions. So those are few ideas that we have about what you can do as a congressional staffer. I'll invite Chiquetta and other members of the panelists to add to those comments if you like.
And in the process, we have about 2 to 3 minutes. So if each could respond with a quick, like probably 20 to 30-second response. Thank you, guys.
Well, I'll just panelists to have any last words.
So this is.
Yeah, I would like to add that we are currently reviewing the National Strategic Plan as well as the NICEM recommendations to identify those evidence-based interventions that could really make a difference in reducing STD rates in this country. So we will be revisiting our National Strategic Plan to make sure that we address and implement these evidence-based interventions as we move forward.
I was going to basically say the same thing. Using the STI National Strategic Plan is a step in the right direction. We have a number of plans for HIV, so having this before us and to open the door for genuine conversations beyond the data will be one way that we can probably, hopefully, have more funding to support STI services and care, throughout the United States and beyond.
And I'll just add to all this, which I 100% agree with, is to consider policies which improve, again, general access to care. So that includes policies related to insurance coverage, potentially Medicaid expansion, and policies which work against discrimination for policy for different populations. We know, for example, that discriminatory policies against, it's been mentioned, the LGBTQ+ population, that policies that are discriminatory against different populations drive down things like testing rates and increase some of these disparities. So from a federal level, just anything to do to improve access to care, improve funding, and to work against some of these discriminatory policies, I think would go a long way.
Well, thank you so much to all of the panelists. Thank you, David and NCSD, for putting together this discussion. I think it's been a very rich conversation today. And we see that it's a very complicated topic, but there are several successful strategies that are in place and many opportunities that are out there to continue this work and be effective in our fight against this STD epidemic. So thank you all for your time. We appreciate the support of CDC, and you all have a great day.
Thank you. Bye-bye.
Thank you all very much.
Thank you. Bye.